Antibody screening and identification. In transfusion medicine, antibody screening and identification are essential for ensuring compatibility between donor and recipient blood. This process involves the use of commercially prepared Group O red cells, which are selected for their specific distribution of blood group antigens. Screening cells and panels. Screening cells typically include 2 to 3 different red cells, while antibody identification panels may contain approximately 10 to 20 different red cells. These reagent cells are mixed with the patient's serum or plasma to detect the presence of antibodies. The mixture is tested under various conditions, at different temperatures, using enhancement media, with antiglobulin reagent, also known as AHG. Additionally, the patient's serum or plasma may be tested against their own red cells, a procedure called an autocontrol, to determine whether an autoantibody is present. Indirect Antiglobulin Test. The IAT is a key method used to detect antibodies that bind to red cell antigens. The process includes several steps. Antibodies in the patient's serum attach to their corresponding antigens on red cells at 37 degrees Celsius, which may result in hemolysis. Excess antibodies are removed through saline washes. If washing is inadequate, residual antibodies and globulins may neutralize the AHG reagent, leading to a false negative result. After washing, antiglobulin reagent is added. If antibodies are present on the red cells, the reagent binds to them. A positive reaction is indicated by agglutination or, in some cases, hemolysis at body temperature. To confirm negative results, check cells, red cells sensitized with IgG, are added. These should produce a positive reaction, verifying that the AHG reagent was active and not neutralized. Additional notes and techniques. Enzyme-treated cells, using enzymes such as physin, papain, trypsin, and bromelain, are available to compare with untreated cells. These help differentiate antibody reactions. When comparing enzyme-treated and untreated cells, certain antibodies show enhanced reactions, including those from the KID, I, P1, Lewis, and RH systems. Others, such as Duffy, M, N, and S, may be destroyed by enzyme treatment. Dosage effects, where antibodies react more strongly with cells that are homozygous for an antigen, are commonly seen with RH, MN, KID's JKA and JKB, and Duffy's FYA and FYB antigens. The strength of reaction can help separate multiple antibodies. For example, a panel showing reactions of 1+ and 3+ may indicate the presence of 2 different antibodies. The phase of reactivity, whether the antibody reacts at room temperature, body temperature, or in the AHG phase, provides clues to its identity. A positive autocontrol across all panel cells may suggest a delayed transfusion reaction or the presence of an autoantibody. Prewarmed technique. When cold-reactive antibodies are suspected but clinically insignificant antibodies have been ruled out, the prewarmed technique can be used. Warm the serum and red cells separately to 37 degrees Celsius before mixing. Wash the cells with warm saline prior to further testing, including cross-matching and panel analysis. This technique helps eliminate reactions caused by cold antibodies and improves the accuracy of antibody identification. The Direct Antiglobulin Test. To begin the DAT, antiglobulin reagent is added to red blood cells that have been washed 3 to 4 times. Washing is essential to remove serum proteins that could interfere with the test. If the red cells are coated in vivo, meaning within the body, the antiglobulin reagent will bind to IgG antibodies and/or complement proteins, depending on the type of AHG used. The optimal sample for this test is collected in a tube containing EDTA, a compound that binds calcium ions. This prevents the activation of complement by plasma antibodies, which could otherwise lead to a false positive DAT. To confirm a negative result, check cells, red cells coated with IgG or complement, must be added. A positive reaction with these check cells confirms that the AHG reagent was added and that it was not neutralized due to inadequate washing. AHG reagents. AHG reagents come in several forms, each designed to detect specific immune components. Polyclonal reagents are produced by immunizing animals and contain antibodies that target multiple epitopes. Monoclonal reagents are derived from hybridoma cells and target a single epitope. Polyspecific reagents contain a mixture of antibodies against IgG and complement components, typically C3b and C3d. Monospecific reagents are designed to detect either IgG or a specific complement component, such as C3b or C3d. In some cases, polyspecific and monospecific reagents may be blended to ensure comprehensive detection of all relevant immune markers. Testing procedures. Using AHG, different testing strategies are employed depending on the clinical context. The DAT is typically performed using a polyspecific reagent to screen for immune coding, followed by a monospecific reagent to determine whether the coding is due to IgG or complement. The Indirect Antiglobulin Test is performed using monospecific anti-IgG to avoid detecting cold-reactive, complement-binding antibodies that are clinically insignificant. As with the DAT, IgG-coded or complement-coded check cells are used to confirm negative results, ensuring that the AHG reagent was active and not neutralized due to insufficient washing. Elution. Elution is especially useful in cases where a direct antiglobulin test is positive due to the presence of IgG antibodies. This can occur in several clinical situations, including hemolytic transfusion reactions, hemolytic disease of the fetus and newborn, HDFN, autoimmune hemolytic anemia, drug-induced hemolytic anemia. It is important to note that complement components cannot be eluted from red cells. Types of elution methods. There is no single elution method that is ideal for all antibody types. The choice of method depends on the nature of the antibody. The Louis freeze-thaw and heat elution methods are typically used for ABO antibodies. Acid elution or organic solvent methods are more effective for autoantibodies and alloantibodies that react at warm temperatures. Last wash control. Before performing elution, it is essential to ensure that red blood cells are thoroughly washed to remove any residual serum that may contain unbound antibodies. This step is verified using the last wash control, which involves the following. The supernatant from the final wash, referred to as the last wash control wash, should be tested either before or in parallel with the eluate. The last wash should show no reactivity with reagent red cells. If the last wash yields a positive result, it indicates contamination with serum antibodies. In such cases, if the test was performed before elution, the red cells must be washed again. If the test was done in parallel with the eluate, the results are considered invalid, and the entire elution process must be repeated. Neutralization tests. Neutralization, also known as inhibition testing, is a valuable method in immunohematology for identifying alloantibodies that may be hidden or masked by other antibodies. This technique involves using soluble antigens to bind with specific antibodies, thereby preventing them from reacting with red blood cells. Several substances are commonly used in this process. Lewis substances, which are found in saliva. P1 substance, present in hydated cyst fluid and pigeon egg whites. SDA substance, which is most abundant in urine, particularly pooled human or guinea pig urine. Cheeto and Roger substances, which are epitopes of complement component C4. These substances help unmask underlying alloantibodies by neutralizing interfering antibodies. Inactivation methods. Inactivation techniques are used to modify or destroy specific antigens or antibodies, enhancing the accuracy of antibody identification. First, sulfhydryl reagents such as AET, 2-aminoethylisothioronium bromide, and DTT, dithiothiridol, are used to destroy or weaken KEL system antigens. A combination reagent known as ZZAP, which includes an enzyme and DTT, is capable of destroying KEL antigens as well as other antigens that are sensitive to enzymatic treatment, such as M, N, S, FYA, and FYB. ZZAP can also remove immunoglobulins and complement from red blood cells, making it useful for enhancing adsorption procedures. Additionally, DTT and 2-mercaptoethanol, 2-ME, can be used to destroy or reduce the activity of immunoglobulin M, IgM antibodies by cleaving disulfide bonds. Second, chloroquine diphosphate is used to remove immunoglobulin G, IgG, from red blood cells. While it does not remove complement, it allows for phenotyping of red cells once IgG is removed. However, it may cause partial denaturation of Rh antigens. Third, acid glycine or EDTA solutions are employed to dissociate antibodies from red blood cells, though they also destroy KEL system antigens in the process. Adsorption. Adsorption is a technique used to isolate or remove specific antibodies from a patient's serum. It serves several purposes: to separate multiple antibodies present in a sample, to remove autoantibodies, thereby revealing any underlying alloantibodies, to confirm the presence of specific antigens on red blood cells. To verify antibody specificity, there are two main types of adsorption. Autoadsorption, which uses the patient's own serum and red cells, is suitable for patients who have not been transfused within the past 3 months. Allogeneic adsorption, which uses the patient's serum and red cells from another individual, is appropriate for patients who have been recently transfused, meaning within the past 3 months.